Good morning, everybody, and welcome to the surgical grand round for this week. Once again, we have a hybrid event. We have people here in the audience, but welcome also to the many of you joining us online. I'm delighted today to introduce Professor Fergus Gleeson, who most of you I'm sure will know already. He's a consultant radiologist and professor of radiology here in Oxford. He trained in Cambridge, Petworth and London and did a fellowship at UCLA in the United States. Was appointed to Oxford in 1992 and is the director of the Oxford Radiology Research Unit here at this hospital. Fergus has published over 200 peer-reviewed publications, both papers and book chapters, and brought in over £30 million in grant income. His specialist interests, which he's going to talk to us about today, are in artificial intelligence, particularly as related to thoracic imaging, PET-CT and xenon MRI. He's currently the PI for three studies, the IDEAL and DART studies, which are multi-center studies investigating the use of AI in pulmonary nodules and lung cancer, and also EXPLAIN, which is a multi-center study investigating long COVID with hyperpolarized xenon MRI. Fergus is the Chief Medical Officer of the National Consortium of Intelligent Medical Imaging, aiming to bring together NHS, academic institutions and industry partners to promote the development and use of artificial intelligence in medicine. Before I hand over, please could I remind everyone at home, please to turn off your cameras and microphones during the talk, and we'll have questions at the end. Thank you very much. Welcome again.
Thank you very much. Thank you. Thank you for asking me. So this is a talk I gave at an Ethics in Artificial Intelligence workshop a few weeks ago, where people were talking about how it's impacting on the law and community, and I was the only person with slides, which was a great advantage because everyone could look at the pictures. Everyone likes pictures, but it's extraordinary how it's impacting outside medicine as well. And because of the audience then, I showed the different definitions of AI in medicine. I'm going to do that with you, and then I'm going to talk halfway through about babies in prams as an example. So just to show you how difficult this stuff can be. I have a number of disclosures which have already been discussed. So artificial intelligence just means not us, but computers. And as far as walking you through it, I'm going to show you the different examples. The first one is CAD-Q. I'm not going to show you an example. That's instead of a radiologist with a ruler, that's a computer with a pair of calipers. And believe it or not, there were about 100 studies showing that a computer with calipers is slightly more accurate than a radiologist with a ruler before we adopted it, so that it's now standard for computers to measure things rather than us. So CAST is the lowest of the low-hanging fruit after measurement. It's computer-aided simple triage, and you can apply that in all different areas. We're going to talk about thoracic because that's the only thing I really understand. But CAST is just, is it normal or abnormal? And that's all it is. So you have a chest X-ray, and the computer determines whether it's normal or abnormal. And the reason why it does that is because if it's normal, it can not have to be reported at the speed as if it's abnormal. So it's a way of triaging the volume of work. Now, that might be important if you have a 4-week or a 4-month delay in having something reported. If you have a 2-hour delay in reporting something, then clearly CAST is completely irrelevant because you're going to report it relatively quickly anyway. So you can see it's a way of avoiding damage by making sure that the abnormal stuff gets reported fast. The reason I mentioned 2 hours, I trained in Los Angeles and you had to report all the chest X-rays within 2 hours of them being performed, no matter where they were. So CAST wouldn't be much use in Los Angeles, but maybe of use in some hospitals within the NHS. Here you can see CAST spotted that the chest X-ray was abnormal. Patient went on and had a CT, and it wasn't the lungs that were abnormal. They were abnormal with emphysema, but actually they had a rib metastasis there at about 4 or 5 o'clock. So that's all CAST does. It may have a role in the NHS, it may not. The next thing is computer-aided detection. That's where it detects an abnormality, doesn't classify it, doesn't quantify it, doesn't diagnose it. It just specifically detects what the computer has been asked to detect. And here is a computer-aided detection algorithm that is used to detect a pneumothorax. So the chest X-ray done on the left, and then the computer outlines where it thinks the pneumothorax is. So it doesn't matter that there's maybe other things on the chest X-ray. It only does what it's been asked to do, which is to detect it. And this actually is now FDA approved. We've used it here in Oxford, done some studies on it. It's on a machine thing, and it's probably a pretty good thing to do. There are some problems with it, as I'll come to, as I'll show you. But that's what it does. So one task, it does it, and that's the end of the matter. And then sort of the holy grail, the thing we all think about, the thing that you go to medical school for and onwards, is to make a diagnosis. See, that's not as important in many instances as you might think, but is the hardest thing to do, where you have to put everything together to try and come up with a diagnosis. And here, this is, again, an FDA licensed algorithm from a company called Optellum. And what it does, it detects a nodule and it gives you the risk, like you would do, of it being a cancer. So it's acting in that respect, just like a human, like a doctor. And because of that, the hurdle for that, in terms of getting licensing and being used, is very, very much higher. So you have to, when you set one of these things up and then you want to be licensed, you have to tell the FDA and others who you've trained it on. The reason for that is that if you train it just on people in North Oxford, and it's terrific in North Oxford, and then you take it over to Australia, it may be completely useless. So you have to specify who you've trained it on, how many, how big the nodules were, how many cancers there were, the type, etc. You can understand the rationale behind it. Now, because of that, you can start to think, actually, this could be quite tricky. And I'll explain why as we go on, why medicine's not static, but the data sets it's been trained on are. So if medicine changes in any way, shape or form, your algorithm may be completely useless in the future. So why bother with any of this stuff? Well, it's because we're humans, because we make mistakes. And it's been known for years that we miss things. You turn right instead of left when you're driving your car. You're tired, you put your keys in the fridge instead of on the table, all that sort of stuff. And so here's lung cancer, and you can see it outlined, and it was missed, and it got a bit bigger, and it was detected. And we know that happens all the time. The literature is replete with stories and data on missed lung cancers, and the Health Safety Investigation Branch, HSIB, have just released a paper on there's a problem in the NHS on missing lung cancers. And we know that patients, unsurprisingly, do worse when you miss their cancer. There's lead time bias in it and things like that. But nevertheless, if you want to do well, you want your cancers detected early. So we know there's a problem, and we know computers help. So why not make use of them? So if they can and will do this, and by the way, they will, and I'll use the word eventually, and we'll come to that, then is it going to make us obsolete? What decisions are we going to make, and how are we going to know how to make them? And there's been a whole bunch of literature showing that at some stage there's going to be a crossover point when actually AI is starting to do the things that only we can do. Now, that you hear the stuff in the paper, on the news, and read it in the papers and things like that about, well, it's already doing it. It's not. It's not close to doing it, and I'll explain why. But if you look, the things I've highlighted at the top, what AI can do, and I started to show you, it can do task-specific things for which it's trained. But you take into account a whole bunch of other things when you're just living your lives, when you're making a diagnosis and doing your job. And unless those have been put into the AI model, it can't do it. So complex tasks, it struggles with at the moment. I put this slide up to show that actually there's now papers published sort of like on an hourly basis on how AI is as good as or is better than doctors. And this is just about AI detecting pulmonary nodules or abnormal lung cancers. And there's just a raft of papers that come through the whole time that are feeding that actually it's going to do better than us, etc. There are real issues with virtually every paper that's published about case selection, and most of them are retrospective. As far as I know, very few AI prospective studies are done in the NHS or elsewhere. And I'll show you why at the end with the prospective studies as the problems that you just deal with the whole time without thinking about it. The algorithm can't deal with those problems in a prospective study. And I'll show you. Okay, so just to give you an example, you're the chief executive and you're fed up that the doctors aren't perfect. If you ask the public, well, I asked my elder daughter who went to LSE, and I asked her, you know, how many cancers do you think we should be allowed to miss on a chest X-ray? And she looked at me as though I was insane. She said, none. I said, what, you mean we have to detect them all? Well, she said, yes, that's your job. You know, it's like saying, how many times can a pilot crash an airplane? The answer is none. So general public's understanding of this is pretty much close to zero. But actually, you'd want the public to think that you were good at your job and want you to be good at your job. So, but there you are, you're the chief executive of your hospital. There's been a missed lung cancer. You think, I'm going to get one of those algorithms. So you get the algorithm and it says the chest X-ray there is abnormal. It says that left hilum is abnormal, it's a lung cancer. So there. So the algorithm's doing its job. Algorithm number one. You then do a CT scan and you've got an algorithm on for CT that detects lung cancers and characterizes them. The only thing is this patient doesn't have lung cancer. They've got a great big pulmonary artery, so you've got the wrong algorithm. And you think, okay, well, I'll buy two algorithms now, or three now. I'm going to buy one that looks for pulmonary emboli because maybe the patient's got pumps, so I'm going to buy that one. So it's like Big Brother talking. Anyway, there's someone down the bottom. All right, so your algorithm spots the pulmonary embolus. So you've got three algorithms done its job. The only thing is it hasn't, because it's not an acute pulmonary embolism, it's a chronic pulmonary embolism that's causing pulmonary artery hypertension. So you're starting to see the complex, you'll just be doing that routinely. You'll just be making your decision, doing it routinely, but you're starting to think, how many algorithms am I going to have to buy to be able to replace a single doctor? And who's going to pay for them? And how am I going to get rid of those doctors? Because they keep finding things that the algorithm can't. And then let's suppose you're in algorithm nirvana. And the algorithm can do everything you want them to do and do them better than doctors, because doctors do it badly. Now you've got a different problem, because mostly the doctors detect things and discuss about having symptoms and then treating the patients. But your algorithm doesn't know that. Your algorithm does what it's supposed to do, which is detect stuff or diagnose stuff, whether it's relevant to the patient or not. And here is a paper from some time back from the BMJ that showed that CT pulmonary angiography was starting to diagnose and spot too many pulmonary emboli. And the reason for that is because your lungs are a filter. They're supposed to filter little bits of rubbish out of your bloodstream and things like that. And humans being humans, we used to be able to see them, and we'd have poor quality scanning, and CT pulmonary angiography had now got better, and it was now able to detect pulmonary emboli that nobody knew you had, that were never causing any symptoms, and nobody knew whether you should treat them or not. But your algorithm is now showing actually that 3 to 5% of the public have pulmonary emboli all the time. So actually, we don't know what to do with that data. And whether you think this is real or not, it is real. So some of the companies are changing the way they reconstruct the data coming off the scanners, and they're making it better. So there is for PET-CT, they are changing the way that they recalibrate and make a diagnosis about how avid disease is, using something called Bayesian probability analysis. And what that has done, it's meant that the avidity of lumps and bumps has gone up. But the studies, for instance, in lymphoma on whether there is residual disease were done on old reconstruction algorithms, and whether the patients were treated or not were determined by that. And now the new scanners, the new reconstruction algorithms are saying that there's avidity that you previously couldn't see. And actually, some of the nuclear medicine communities have said, don't use the new stuff because we don't know whether to treat the patients with it. So actually, that's going to be a big problem with artificial intelligence. If it is better than us, we're not going to know what to do with information it produces for us. Obviously, all of these things will be solved over time. So maybe this is the Dunning-Kruger effect, which is one of the things that I think radiology suffered from right at the very beginning, which is that if you know very little, you might think that you're good at it. So if you actually play a bit of squash, you think you're very good at squash because actually you don't know, you've never played people who are very good. So you overestimate your ability. You must admit that the whole time in your lives. I know I do. That's an in-joke about Dunning-Kruger. You have to go away and think about that one. But so it basically means if you know very little, you might overestimate how good you are. Also, if you know an awful lot or you're very good at something, you can't understand why other people can't do it. And so that may be one of the things that people think they can, it's just looking at pictures. That's all radiology is, looking at pictures. That's what everybody thinks. And I can do that, is what people think. So, and there's the thing about if something is very complicated, it has a very complicated solution. Simple answers, uniformly incorrect. And I've put something, Charles Darwin got it, and Mencken, who's an American journalist, about actually it's slightly more complex. And the reason I mention that is that the chief executive of Google, I forget what his name was, said 5 years ago, he said, stop training radiologists. We don't need any of them because we can just do this. Well, Google haven't licensed an algorithm. They spent $5 billion trying to develop them. So actually, it's slightly more complex than identifying cats on the internet, thank God. So that's sort of the complexities of it. But one of the things you have to think about is how good are we? Now we know that there's going to be a way of determining whether we're good at something. How good are we at doing our jobs? We're certainly not as good as my older daughter wants us to be, which is never getting anything wrong. And the reason I mention that is this is a study done in Oxford by Alex Novak. And what he showed, he's one of the ED consultants for detecting pneumothoraces. He showed that with and without the algorithm, the staff in ED got better. It involves nursing through to junior doctors, through to senior doctors. They got better, which is great using the algorithm. None of them were perfect, but of course, this is the first time you can see actually how good you are on a click of a button. And you can see how good you are against a benchmark that can be used in Nuneaton through to Truro. So how are we going to manage that? So this is the sort of stuff that you have to think about. So I'll just show you a few things, which is we're supposed to measure how good we are. We're supposed to have annual appraisals to measure how good we are. Yeah. And it's the top right is from the GMC about comparing yourself to your peer group. But that's impossible, isn't it? You know, all the surgeons here can't compare the surgeons themselves to the surgeons in Nuneaton. They might be able to compare themselves to each other, but that's hard enough. But actually, once you start to get algorithms in it, algorithms are place neutral, they're people neutral. So we're going to have a benchmark. And the top left is a graph showing But actually, if you train people in interpreting chest x-rays, this was, top 20 is the far left of the AAC, bottom right is the people who weren't trained of the AAC, and interpreting for looking for lung cancer. So if you train people, they get better. So we know, therefore, that if you can find out who's not very good at their job and you train them, they will get better. What we don't know is how to find people who aren't very good at their jobs at the moment. Everyone says, oh, well, I know that person. They're not very good. I'm not going to go to that person. I don't really know that. They've got no quantitative measure of doing it, but we're now going to. The other thing is the bottom right is a flight simulator where pilots have to be tested every 6 months as to how good they are at their job. So other professions do this, and you have to reach a threshold with your flight sim. Actually, it's set by individual airlines. So how good you are on a flight sim is different for BA compared to another airline carrier. They don't all have the same thresholds, which I think is, they all have to be approved thresholds, but they're not all the same. But ours could be the same. It may be that you don't have to be as good in nether wallop as you do in outer wallop. I don't know that, but we are now going to start to have a threshold that can be applied to determine how good you are. Are we going to be mandated to do this? Who's going to report what threshold, etc. So the reason why that's important, here's the pulmonary nodule. Is it a lung cancer or not? So they had 400 of these, study done by Uptellum, different readers, and they all had to determine whether they thought this was likely to be a malignant or not. They then gave them the results of the algorithm, and all the readers got better using the algorithm. They all got closer to whether it was cancer or not, but they didn't get better for every nodule. And not every reader got as better as that's not English, but never mind, got as better as everybody else. It didn't make the same improvement for everybody, and not every nodule did they get better, but overall, everyone got better. But how is each individual doctor going to make the decision as to whether the algorithm is actually making them better or not if they don't know how good they are? So if they don't know how good they are at diagnosing cancer on a CT scan from a pulmonary nodule, and someone gives them an algorithm, how do they know that that algorithm is better than them? How do they know it's better than them for that specific nodule? You imagine, so this was the ethics and AI thing where, you say, well, the algorithm said it was a cancer, so I took it out. A patient died and it wasn't a cancer, but it's the algorithm's fault. Is it? Or I thought the algorithm told me there was no chance of it being a cancer, so I discharged them because they were 25 and they didn't want lots of x-rays and CT scans and follows up and biopsies, and it turned out to be a cancer. But it was the algorithm, and the algorithm's been licensed by you, and the hospital's paying for it. So I'm going to do what the algorithm says or not. So why is this so difficult? So here's the babies and pram analogy. So we got limitless money, and we're going to develop an algorithm across the world that identifies babies in prams. The baby's the nodule, the pram's the CT scan. So that's what we're going to do. It's very easy, isn't it? You think, I'm going to give you $1 billion to identify and to produce an algorithm that identifies babies in prams. The only thing is, none of us know what a baby is compared to, when's a baby stop being a baby? When's it become a toddler? When's it a neonate compared to a baby? Does everybody around the world agree on that? Does every baby look the same? Are we talking about babies facing forwards? Or is the algorithm going to make a diagnosis of a baby from the back of its head with a cap on? This is getting slightly harder. I may need more than a few $1 billion to be able to do this. And then that pram stuff, do I know what a pram is? Does every pram look the same? Is every CT scanner the same? It's slightly tougher than I had thought. But we cracked it in 1922. We developed an algorithm in 1922. We were cleaning up. Our algorithm could identify prams around the world. There was no problem. People were paying us a lot of money to use our algorithm to determine whether something was a pram or not. The only thing is, medicine changes. So the algorithm for the pram in 1922 can't identify a pram in 2022. Hasn't got a clue. Goes, well, that's not a pram. Medicine changes. The country spent about 20 million and the world spent a couple of 100 million to identify and diagnose the severity of COVID on CT scans and chest X-rays. I was part of the committee and I was going, don't do this. Don't do this. This will be a waste of time and money. And they were, no, because actually all these patients are coming in and we want the scanner, we want the algorithm to do this so the doctors can get on with looking at. I'm just going, don't do this. This won't work. And they're going, yeah, it will. I'm going, it won't work. And the reason it won't work is because the patients are going to come in at different degrees of COVIDness. Some of them are going to come in early. Some of them are going to come in late. Some of them are going to have interstitial lung disease. Some of them are going to have heart failure. And then with a bit of luck, someone's going to have a vaccine that's going to actually make the whole thing change as well. And then we have the recovery trial. So not a single algorithm around the world has been used in anger to help with COVID, even though hundreds of millions of dollars were spent developing these algorithms. And that's a good thing because medicine changes, technology changes. We've got new PET scanners. So as I'm talking about, okay. Someone's decided, and there's something coming up called the secure data environment or the trusted research environment, where the data stays in the hospitals and you develop algorithms. You move the algorithms and develop them in the hospitals rather than take the data out. That's great because it means the patient's data is secure. The slight problem with it is that actually I may think that a pram's a pram in one place and someone else may think a different pram is a different pram in another place. So how do you make sure that everybody behaves the same in Nuneaton versus Penzance? The answer is it's very difficult to do it like this, which is why the companies like all the data in one place. They can quality control it. They can make sure that a pram's a pram, and then they can develop their algorithm. So that's really difficult. And then, of course, you are used to looking at, you're happy to look at most of those images and go, well, actually, that's not great. That's black and white. It's a bit blurred. That's a baby in a pram, etc., etc. But algorithms don't like poor quality images. But you can't say, well, I'm not going to diagnose you because actually you're too short or you're too tall or the image isn't. You get on with it. Algorithms struggle and we get blurred images. And then, of course, the thing that medicine does par excellence is takes time. Takes time. The reason why hospital doctors are often better than general practitioners in making a diagnosis is because by the time the patient gets to hospital, the disease is more overt. And actually, if you go back, you say to the patient, well, when do you start feeling ill? And they're not particularly sure. So so here we go. There's a pulmonary nodule bottom right. There's a baby. Does anybody know who that baby is? Does anybody know where that pulmonary nodule is cancer? It's getting a bit bigger, so we're now definitely worried that that's a cancer. We're beginning to wonder who does that child look like? It's hidden now by the thing. Child's got bigger, the nodules got bigger. So medicine over time, that's how we'll bring you back in a month. We'll do another test. We'll bring you back. If you're a junior doctor and you rotate every 3 or 6 months, you bring people back at 4 and 7 months, don't you? So you give them time. We don't do snapshot stuff. Algorithms do snapshots. They take it then and they say that's what it thinks it's going to be. That's Arnie. Yeah. It's impossible unless you're his mum, I guess, to have known it was Arnie when even his mum would have had problems, I think, predicting Arnie was going to be Arnie. But actually, so algorithms and time is something that's got to be played in. And the reason I mention that is here's a paper from Google DeepMind showing that actually their algorithm was probably as good as most doctors until the doctors had a sequence of images. And that's what we do. We take into account lots of things that the algorithms don't have the opportunity to take into account. So more than just images, we take into account where the patients come from, their prior surgery, their drugs, the scanner type, given contrast, etc. And then you put it in context. and you do that without thinking about it. So far left, the pneumothorax is enormous. You don't even blink about it. You know it's a large pneumothorax. Patient's got a chest drain in, and you're just doing the chest X-ray to see if the pneumothorax is getting bigger or smaller. So the chest drain's the clue, etc. But the thing that is difficult for us all is unsuspected disease. So whether there's an unsuspected pneumothorax, yeah, out of context, you're not suspecting it. The problem being, have you bought the algorithm for the pneumothorax for that chest X-ray, or is it a lung cancer algorithm, or is it a cast algorithm, you know, etc. So how you do that. And that's been the problem with quite a lot of the self-driving cars. So when Google's car hits the person who was pushing their bicycle crossing the road, it's because the person was pushing their bicycle rather than riding it, and the algorithm didn't identify because it hadn't been trained to identify someone who was pushing a bicycle as opposed to riding. So we would think we don't have a snowman there on a farm or a duck watching a television. You can get your algorithm to identify a duck or a television, or you can identify a bicycle, but the wrong way up on a beach, etc., etc. So you're starting to see how complex this stuff is. And here's two examples. The one on the left is where the image gets worse. You still know it's got a dog, a skier, and a building, but the algorithm about halfway through goes, I can't do this because the image isn't good enough. And the one on the right was an algorithm trained to identify COVID on a chest X-ray, and it was very good. And when they gave the algorithm a picture of a cat, it knew that that was COVID. So, and the reason for that is the algorithm had never seen a cat. So its result was, as you can see, it was pretty near 100% that that cat was COVID, not had COVID, but was COVID. Okay, so can only give the algorithm things it's been trained to see. So here's just a lung cancer there, top right, like that, but it's an AP semi-erect. So when you develop your algorithm, you have to do it on all kinds of imaging. So we've got algorithms now. Who's going to use these things? Do you have to be Einstein? Do you or can any old Muppet use it? So what they want, everybody, is not to pay doctors as much, to make doctors much more efficient because they're very expensive, very highly trained, and they want to downshift some of the work or upskill some of the other staff. Really sensible. But how we do that safely and how we train people to do it has yet to be worked out. Most of the companies put thresholds with their algorithms that they're licensing now, so that the person using it has to determine how sensitive and how specific it is, so that actually the person using it is liable for the results, which is perfectly reasonable. You're liable for whether you give 100 milligrams or 200 milligrams. You make those decisions all the time for therapy, potentially the same for algorithms. But that requires a lot of training and a lot of decision making, and it's quite difficult. And to show you, here is part of the prospective ideal study that I've been doing around the country to determine whether an algorithm is better than we are at diagnosing lung cancer. That pulmonary nodule put in down there, is it a lung cancer? The only thing is, it's not even a pulmonary nodule. It's an area of subsegmental linear atelectasis, and for whatever reason, maybe it wasn't available, I don't know, the person interpreting the scan didn't look at the coronal recons and thought it was a pulmonary nodule. Mistakes happen, as I've said. But it went into our machine and the algorithm gave a likelihood of it being a cancer, but it should never have been put in. So who will use these algorithms and how do you train them? And then who will pay for them? Yeah, because what you can't do is you can't just put algorithm and after algorithm after algorithm in at more and more cost. And they're not going to be cheap. They take tens of millions of dollars to develop a single algorithm to do something, 20, 30, 40 million dollars just to develop a cast algorithm that just says normal versus abnormal. So we're going to add all of those onto the costs in the health service. How is anybody going to make that decision? Who's going to pay Are you going to pay per hospital, per algorithm? Are you going to get Siemens or GE? Are you going to say, we're just going to do a deal with them? Is it going to be for your hospital? Is it going to be for the whole of the NHS? Maybe Siemens have got 50% of the algorithms you need and Google will have 50% of the others. How is that going to work? So I just move back to there. And then what we really want to do after we've got those algorithms is get to the nirvana of algorithms, which is there's a whole bunch of stuff that we can't do. We try, but it's very difficult. And here is the DART stuff that we're doing, which is a multi-centre study across England with NHS England and the lung health check centres who are helping us. And we're collecting all the clinical data, all the age, the sex, smoking history from all of these patients. We're collecting their lung function, their CT, they're having blood taken, and digital, we're doing pathology and digitizing it. And we're going to put it basically in a big pot. We're going to put it in a big pot for the algorithm and say, we want you to help us identify who's going to get cancer, how bad their cancer is going to be, and what treatments we need to give them. And we'll have about 600,000 participants. We've got about 78,000 now. We'll have about 600,000 by the time we're done. And the reason for that is we struggle as humans to put all the stuff together, but the algorithms can do things that we can't. And here is one that was developed by Min Suk Kim, one of my postdocs. And the moving CT on the right is from a static breath hold CT. The patient lay on the CT scan, breathed in, held their breath, and 0.25 or so of a second later, or 2 seconds later, they had their CT. And then you put into the algorithm, you put in the images, you put in the patient's lung function, and it calculates the tissue elasticity, and it gives you a ventilation map of the patient's lungs. So that is how the patient's lungs are ventilated, as though it was a ventilation scan. So the algorithms will be able to do things that we can't get close to doing. So that literally is how that patient's lungs are ventilated. So every patient that gets on a CT scanner will be able to have one of these things, and then the thoracic surgeons will know whether the left upper lobe is well ventilated or not. They'll know whether it's well perfused or not. They'll be able to calculate what will happen to the patient's lung function if you take the left upper lobe out. They'll be able to determine whether they can have radiotherapy instead of surgery, because they'll know what happens if they did either. That's what the algorithms will be able to do eventually. Then how do you regulate them? So as I said, medicine changes, and you get your algorithm, and then actually version 2 comes out, and is version 2 trained on the same data as version 1 was trained on? Is it from a different country? Do I have to keep upgrading my algorithms? Do I have to keep retraining them? How do they get relicensed? They can't. The licensing authorities really don't like continual learning from algorithms, but you do that the whole time. Because the reason they don't like it is because they can't control what's going into the input, and they can't control the output because they can't validate it as you retrain. And this is what you can do the whole time. So this is either a young lady who's got a quiff at the front and you can see the tip of her nose, or it's an old lady with a chin down in the bottom round about 7 o'clock wearing some form of headscarf. Or you can flick between the two of them the whole time. You don't mind, you can just manage that uncertainty. The algorithm can't produce an answer that says, well, I think it's both an elderly and a young lady, and actually I'm quite happy for it to go back and forth between them the whole time. You can do that. You can manage uncertainty. In fact, that's probably the biggest thing that intelligent people doing medicine do, is manage their uncertainty. Is go, I don't know what it is. I think on balance it's likely to be this, or I'm not sure whether I should operate, but I think on balance I should operate, and all the rest of it. They don't go 100, most of the time, 100% of the time, I know what's wrong, 100% of the time I know what to do, and 100% of the time I know what's going to happen. You manage those uncertainties and you change how you practice. And then we've got all the problems we're going to have about, and this is a biggie for most of you that are young, is, and doesn't seem to be addressed. For instance, the Labour Party is going to train 7,000 additional new doctors or something like that. I forget what the number is, when they get into power in 2025, four or five. and then it's going to be another 6 years to train them. So we're talking 8 years away. Does anybody think in 8 years' time medicine's going to be the same? And by the time those doctors are 5 years into their career in 13 years' time, so we've got to work out how we're going to train people in the future. And if you think, well, that's not the case, in some schools in America, they've stopped teaching handwriting. Stopped. If you ask my elder daughter, who I'll keep using, she actually did every exam. She's in her 30s now. We thought we were smart, so we bought her a computer when she was about 5 and said, don't worry about writing, learn to type. So she can't write. Okay. She doesn't need to write. She's got VR and typing. Why does she need to write? When you go to school, you don't need to write any longer. That's a historical thing, isn't it? Like block printing. We don't teach block printing any longer. I remember block printing. So we need to think of how we're going to train people in the future using these algorithms. But eventually, it's going to be marvellous. And then we won't need doctors and it'll be game over. But it's a long time away in the future, I think. Thank you very much.